Okay, I'm going to share the screen and get started. And as I say, please feel free to chime in if you have a question or want to make a point about anything that we're going over in the next 45 or 50 minutes. All right, so you should see my slides now. And what I'm doing today is providing some highlights from a satellite conference for LEPH that we ran last week with a lot of help from Temple and a good video productions team there, and Bethany and all our participants. It was a virtual conference funded by the National Science Foundation. And my co-conveners were Rosemary Faso at Thomas Jefferson and our own Jennifer Wood, the leader of this whole LEPH Philadelphia enterprise. Our aim was to introduce people who work in policing and public health, whether they work more on policing or more on public health, they're right in the middle, to the emerging field of legal epidemiology. And within that, to provide an opportunity for early career researchers working at the intersection of these topics to share their work and interact with some of the leaders in the field. We had 11 abstract presentations focused on methods, issues, as well as results, and 2 plenary conversations with a group of leaders in legal epidemiology and in policing and public health. The nice thing is that you can see all short videos for each of the papers, read an extended abstract discussing some of the challenges and findings of the papers, and see these plenaries recordings all at our website at the Center for Public Health Law Research. Today, I'm just going to present some of the highlights. I started out the whole conference with just a brief introduction to why we have a field of legal epidemiology and what it's all about. And the underlying driver is intensely practical. We understand, and I think it's not really very much disputed, that law is actually sort of crucial to public health, both in the sense that we frequently use law as a mode of intervention to change behaviors and environments, but I think even more fundamentally because law itself operates as a mediator and as an actual supporter or reproducer of the social determinants of health. So in this kind of basic social determinant schema that you see here, we generally understand that deep factors in the social fabric, access to resources, social position, influence health. They're really the biggest drivers of health, and they do so along the life course through various kinds of experiences that people have, socially structured experiences which interact with their socially structured vulnerabilities or capacities. And law operates as one of those mediating forces, as you see here. Drug laws change people's lives and their health outcomes, and they change them differently depending on where people started in the social structure. A fine and a $10 fine means one thing to somebody whose annual income is $10, and another to a person whose annual income is $100,000. But at the same time, law is also contributing to the deep context. So the easiest example to give there is the tax code. That massive law has done more to shape the distribution of resources, wealth, and income in our society than any other single factor. And it has shaped it quite dramatically. When I was born 65 years ago, we were in the United States, we were at our most equal or most homogeneous in terms of the distribution of income. Now we're nearing maybe surpassing our most unequal point. And the single biggest driver of that change was the set of tax changes that began during the Reagan administration and have continued to pace since. that have allowed more and more of the wealth of society to concentrate in fewer and fewer hands. So we understand that law matters to health, but exactly how? When does an intervention work? When does it cause side effects? How can we change laws so that social structure is more equitable and more healthy? That is the realm of investigation of legal epidemiology. We used to call it public health law research when Jen Wood and others were starting this whole enterprise up at the Public Health Law Research Program from the Robert Wood Johnson Foundation. But later, through the intervention of people at CDC, it became known more as legal epidemiology. But the definition remains the same: the scientific study and deployment of law and legal practices as factors in population health. And I think one analogy summarizes the rationale for all this. Typically, we just don't know that much about law's health effects, deliberate and incidental. We don't know whether law is having the effect that it's supposed to have. We don't know whether it has side effects. Often we don't even know where it's been adopted, so we don't even know who's been exposed. And all you have to do is imagine that this were a pharmaceutical treatment instead of a legal treatment. We would never operate in this kind of blind manner when it comes to effects and side effects if we were talking about drugs. And yet law is a treatment. Law is a treatment that's administered on a mass scale for extended periods of time. We need to know what effect it's having. So that was the starting point of the conference, the introduction. We began with a plenary conversation I had with two of the people who helped develop the Public Health Law Research Program and the field, two really outstanding leaders. One is Alex Wagenaar, who was the preeminent alcohol policy, alcohol road safety, alcohol excise tax researcher for many, many years, who really thought up legal epidemiology before it had the name, and who was instrumental in developing strong methods for evaluating the effect of the law. And that's where we started on our conversation. There is still a real barrier to getting health research funding for legal epidemiology that is tied in part to the insistence that only a randomized controlled trial can give us results that support strong inferences of causation. So Alex took on that shibboleth in his comments.
Well, on methods, I think maybe a major current problem in the field that we could discuss a little bit regarding methods is the simplistic dichotomization of study designs into RCTs, randomized controlled trials, versus, quote, mere observational studies, with the former leading to causal inference, RCTs, and the latter purportedly not valid for causal inference. This, I think, is a mistake. Mm-hmm. Randomization is a great design tool to improve causal inference and should be used whenever we can use it. But what's important to realize is there's many other great design elements to improve causal inference. And the creative combination of many design elements can achieve stronger causal inference even than a study using random assignment. What kind of design elements are we talking about? You know, it's the things that we know. Using many repeated measures, perhaps hundreds or thousands of repeated measures in time series studies. It's taking into account the functional form of the effects of a particular law or policy. It's not just the pre-post difference that we're looking at. It's, does the form of how the effect rolls out, does it grow or evolve over time? matching the theory that underlies the law or the intervention, or does it match the implementation, the rollout and the implementation of a new law or policy? And we can use comparison jurisdictions. We can use comparison groups within those comparison jurisdictions. We can use comparison outcomes within the groups that are within the jurisdictions that are passing these laws. That is, we use multiple comparison groups that are relevant, plus we can hierarchically or nest those comparisons to make very strong research designs. And we have things like replications of a policy. People do it across units, across states, across provinces, across organizations, and they do it across time. So we have replications over time. And we can do dose response sort of studies with laws, looking at the intensity, if you will, or maybe implementation fidelity, and see how the effect of the law changes based on that intensity or that implementation fidelity. So, I mean, we have a lot more details on this. You can see our natural experiments chapter in our book on public health law research methods for more. But
so, Alex makes the point that we actually can find out if laws are working through well-designed quasi-experimental studies, and that's sort of our gold standard. With, also, we could go on and on about external validity and the way that there are certain advantages to actually looking at the law in vivo observationally over an artificial, lab experiment. One of our young researchers, Tarly Townsend from NYU, gave us an example of this, looking at offering us a study of the impact of Good Samaritan laws that all states, US states now have, to provide some level of protection for people who call for emergency assistance in an overdose. Thing about these laws, though, is that although every state has them, the active ingredients are quite different. The laws vary in really significant ways. So she talked a bit about that.
So the challenge, though, to studying this question is that these policies are enacted in the real world, right? And lots of other things are happening in the real world. So a key challenge for causal inference around the effectiveness of Good Samaritan laws is that those laws are often co-enacted with naloxone access laws. You can see in this figure on the right how GSLs and NALs are kind of moving together over time in terms of the number of states that have them. So how do you tease out then the effects of one law from the other? Similarly, these laws are often passed amidst a rise in fentanyl-related overdose. Now, if fentanyl is influencing mortality and Good Samaritan laws may be influencing mortality, again, how do you tease out the effects of each of those things separately? For the methods wonks out there, we have this problem of the parallel trends assumption often being violated. That assumption is key to a lot of our kind of common econometric strategies for evaluating the effects of policies. And finally, because so many states have enacted Good Samaritan laws by 2018, if we want to look at the effects of these laws in overdose in recent years, we run out of comparison states, right? We run out of states to compare to or control states that haven't implemented the law. So in the context of all of these challenges to causal inference, we've been thinking about how we can do a good job of studying racial disparities and the effects of GSLs. So in this study, we evaluate the impact of Good Samaritan laws on overdose mortality per population using data from the National Center for Health Statistics. And those data are from 2015 to 2019. And we look at overdose mortality in Ohio and Michigan separately, overall, and in white people specifically, and in Black people specifically. And I talk more about the methods in the methods brief, so this will really just be a general, not even an overview, but we use this method called synthetic control method, except we've added kind of a novel spin to it in order to circumvent the serious methodological challenges that I talked about on the last slide, or some of those challenges at least. And so we think that this is really an improvement on what we've been able to do in past research. So what we were doing then is comparing Ohio and Michigan, which had, those were the enactment states. So they had naloxone access laws throughout the 2015 to 2019 time period. So nothing was changing in terms of NALs in those two states, but they gained a Good Samaritan law in the middle of that time period. And then the comparison states were actually states that had a Good Samaritan law and a naloxone access law throughout the time period. So what do Michigan and Ohio's Good Samaritan laws actually say? Well, they're pretty similar on some dimensions. Both provide protection from prosecution for low-level drug violations, but Ohio's is a little bit more expansive in the sense that it also provides protection from arrest. And you can think about how that matters. You know, if you're going to be, you know that you may still be arrested after calling 911 at an overdose event, that really may be a pretty severe deterrent from calling. But neither Michigan nor Ohio protects from violations of probation or parole, and neither protects for paraphernalia possession. Ohio has two additional really important caveats. The first is that a person only receives these protections if they receive a referral for substance use disorder treatment within 30 days. And there's this two-strike caveat where they have to have, they can only have benefited from the Good Samaritan law twice in total before they stop receiving these protections. So what did we see? Well, in Michigan, interestingly, we saw no clear effect of the Good Samaritan law in the overall population, in white people, or in Black people. So really no apparent effects of the Good Samaritan law on overdose mortality in Michigan. In Ohio, the story was slightly different. We did see some decrease in overdose mortality that appeared to be attributable to enactment of the Good Samaritan law. It was about 12% in the overall population. But we only see this when we break down by race ethnicity. We only see this effect in white people. We don't see a clear effect in Black people. Now, part of that might be the N problem, right? That the sample is smaller for Black folks. So that's something that we're working on discerning. So what are our big picture takeaways here? Well, we didn't see any effects of.
So this is, a great example of how researchers are trying to improve through both design and analysis the causal strength of observational research on law. It doesn't change the fact that it is really hard to do. Good Samaritan laws have a very muted signal at best. There's all sorts of practical problems with them that qualitative research has shown, and whether people are willing to rely on them. This kind of work demonstrates that we can probe pretty effectively whether or not these laws, what these laws may be doing, and whether they're worth our efforts to keep implementing and try and advocating for. Well, so we also had a really interesting panel with some people in both research and practice, including Brandon Del Pozo, who is now a researcher, but was a police chief and police officer for many years, Oscar Alleyne, who's at the National Association of City and County Health Officers, and Tim Akers, who was one of the originators of the idea of epidemiological criminology, which is sort of I would say a subfield of legal epidemiology. And Brandon talked a little bit about,
at least, having been in policing for 23 years, certainly coming up as a rookie, actually patrolling Oscar's neighborhood when I was a young man. The idea that policing could have an effect on health was sort of a foreign concept to the police. And there were people studying the negative effects of policing, but we're finally coming around to the thought that if policing is going to fulfill the role we need it to fulfill in our communities, it has to be conscious of its health effects and also be instrumental to better health outcomes, not just, minimizing the poor ones. And so I think for me, I think that makes the unanswered question not what effects does the law have on policing, but what effects does the police discretion and interpretation of the law have in terms of health on policing? And so
that question of police discretion is crucial to understanding the big gap between law in the books and law on the streets. And it was again something that our presenters and participants in the NSF satellite looked at. So another NYU participants, Bruha Joshi, were looking at using survey methods to try and probe some of the differences in how local police were deciding to enforce their state marijuana laws, which, as you know, have been going through a huge period of change.
So the study aims here were to primarily examine what is happening at the current across law enforcement agencies across the country. What are they actively focused on? How do we ensure equitable enforcement? And do these enforcement strategies of these law enforcement agencies vary by community characteristics? So in order to do this, we conducted a national survey of law enforcement agencies. The survey was actually a follow-up of a national survey done of law enforcement agencies in 2010. The primary focus of this survey here is on alcohol-related enforcement. However, in a 2019 survey, we expanded the survey to include questions on marijuana and opioid-related enforcement activities. This, building on the original sample, which included around 1,000 large and small agencies from all across the 50 states, we, for this 2019 sample, also included an additional set of agencies in order to obtain 50% coverage. And when I say 50% coverage, I mean population coverage that these law enforcement agencies have within their jurisdiction of the 100 and most populous counties across the country. This was due to the fact that the outcome that we were using for our alcohol-related enforcement was available at this level. The survey was primarily conducted, we had hoped that the survey would probably be conducted via email, but what we actually found was that with this kind of two-response system set up for email, we ended up doing close to half of our interviews on phone, but a little bit more were done via email. The final sample resulted in 1,030 agencies out of the original 1,631 that we attempted to contact, so resulting in an overall response rate of 63%. The survey had four main components: agency characteristics. So this included things like how many sworn officers do you have? Do you have a full-time officer that is in charge of alcohol-related enforcement, for example, or marijuana-related enforcement? Then we asked specific questions related to the three substance use outcomes of alcohol, marijuana, and opioids.
Let's just jump to some results here. Let's see.
We were interested in what is going on with decriminalization across these jurisdictions. And so we asked this question of, does your agency actively enforce the possession of small amounts of marijuana intended for personal use? Here, we had a vast majority of agencies report that yes, they do so, with 624 agencies out of the close to 700 agencies reporting that they do this, while 63% reported no, that they do not enforce small amounts of marijuana intended for personal consumption. We also asked these agencies what their metrics for personal use were, and these ranged extremely broadly. So we're going down from 0.5 gram to up to 8 ounces. Around 70% of these agencies said that personal use was defined as less than 1 ounce, but there was also wide variation between 0.5 gram and 1 ounce, suggesting that there is stark variation in what what law enforcement agencies believe is small amounts of marijuana for personal use.
Obviously pretty intriguing findings, but also pretty impressive that they could get a 63% response rate on a survey and be successful in using surveys to start exploring police exercise of discretion in this, very fast evolving field.
So this
implementation more broadly was something that Oscar was very interested in as a line well, as a former line state, county epidemiologist and somebody who's now working on policy for the National Association of Health Officials at the local level.
You are absolutely correct. If we wait until data is collected, data studies, retrospective, long-term, et cetera, we're going to miss the boat. But there's a side that we actually utilize in the practical sense of, at least on the public health lens, called implementation science, where you're looking at what is being done and in vivo, and you're able to almost, I would say, build it or construct it or evaluate it as you're flying it. Right. So in that regard, you're able to get a much more real-time assessment and review as to what interventions, activities, suggestions, or the research developed objectives are able to be influenced while you're looking at the full implementation of a strategy, which you're trying to have a much more immediate response or immediate effect on, while at the same token ensuring that it's meeting the rigor and the guidance that we would have for applied research and science. So
obviously, Oscar is sort of talking our language here in
I would
terms
say
of the, the life of a criminologist or somebody who's trying to follow what's going on with police and the effects of interventions. So we had a good example of research in that line from another NYU researcher, Bennett Alleyne, who asking a really simple but important question, which is, okay, we have laws aimed at criminal prescribers, doctors who are misusing their prescribing powers. Criminal investigation, prosecution, that model of incapacitation is about the most intense form of regulatory action you can take in terms of its use of resources. So, it seems like an important question to ask, whether deciding to use that law on anything like whether that law is being used on any kind of systematic basis, and if so, what effect using that law is having.
So to do this, we used two data sources. We used retail pharmacy prescription dispensation data and prescriber arrest information. Our prescription data, we looked at monthly opioid analgesic prescriptions at the county level for all the 5 counties comprising New York City and the 2 counties in Long Island from 2011 to 2018. We included all Schedule 2 and 3 formulations as opioid analgesics, but we excluded buprenorphine, which is used primarily for opioid use disorder treatment. We also, our prescriber arrest data, we drew from public announcements made by the federal prosecutor's offices announcing the arrests of prescribers on charges related to OA sales or OA distribution. We excluded cases that were for drug-induced homicide or that were related to patient deaths in some way, or opioid-related overdose deaths. Our exposures and outcomes, we considered each prescriber arrest an individual county level exposure for the county in which the prescriber's practice was located. That's not necessarily the county where the prescriber lived. We considered the 6-month period before their arrest unexposed time and the 6-month period after the arrest exposed time. We examined 4 county level outcomes for each arrest. We looked at the overall rate of prescriptions, we looked at high dose prescriptions, we looked at prescriptions paid with cash, and finally we looked at prescriptions OAs co-prescribed with benzodiazepines. So high dose and cash payment prescriptions in particular, as well as benzo co-prescriptions, could be considered proxies for non-medical use. Although we want to be judicious about making that leap. Our statistical analysis was threefold. First, we looked at descriptive statistics for all counties and all outcomes, as well as the 2 jurisdictions overall. We also conducted interrupted time series models separately for each arrest event and each outcome. So we use negative binomial segmented regression models that I discussed in some more detail in the methods brief, as well as using a 6-month window on either end of the arrest to avoid overlap within counties. Finally, we use meta-analysis to look at generate an overall estimate of the associations between arrests and each outcome for the 2 jurisdictions overall. So our arrest, in the meta-analysis, we treated each arrest event and each interrupted time series arrest model of the arrest event as individual studies, and we used random effects to permit population variation across counties and the jurisdictions. We also conducted a post-hoc sensitivity analysis for an additional meta-analysis that excluded an outlier event in New York City that I'll discuss later. Results. So we identified 23 arrest events during the whole study period, 12 in New York and 11 in Long Island. So these are not common events. During the study period, the overall number and rate of OA prescriptions in both overall jurisdictions changed, and as well as for all 4 outcomes in each of the 7 counties. Looking at county level changes in OA prescriptions, the results from our interrupted time series models, these showed that county level changes varied in the 1 and 6 month time periods after arrest events. So while some events resulted in 1 month increases or decreases in prescription outcomes, very few of these changes were sustained across the 6 month period given following a given arrest. So for example, given the volume of our results, I'm only going to share a couple examples, but please do feel free to contact me if you'd like to explore the results a little more. So in the 1 month period after the arrest in New York City, for example, there was a decrease in cash payment prescriptions in Richmond County, although this was not sustained. And likewise in Nassau County in Long Island, we saw a similar decrease in 2012 after an arrest event. Looking at overall changes in OA prescriptions, the results of our meta-analyses, these indicated that prescriber arrests did not have an overall impact on the prescribing outcomes that we looked at in New York City and Long Island during the study period. While there was an overall decrease in the rate of cash payment prescriptions, we did find that an incident rate ratio of 0.95. This attenuated just slightly when an outlier event was removed. Our study heterogeneity additionally ranged from 79 to 98% across the 2 jurisdictions.
So, that's pretty striking finding in terms of lack of effectiveness, but also not surprising. But this study didn't even begin to look at side effects and the possibility that cutting back on access to improper but legal prescription medications might lead to greater overdose death, for example, through people moving to illicit sources of non-pharmaceutical opioids.
So what are the implications?
Now, all this work, or not all of it, but much of it, does depend on measuring exposure. You have to capture what the details of the law are and how they vary across time and space. And doing that accurately has been one of the contributions, I think, of the field, starting with the work that Alex Wagenaar did years ago with the Alcohol Policy Information System, and then moving through the development of policy surveillance within the Public Health Law Research Program of RWJF, and now sort of exported around the world. We'll just hear from one of the staffers at the Center for Public Health Law Research, who talks about the basics of that in this presentation.
Hi, my name is Alex Hess, and I'm a law and policy analyst at the Center for Public Health Law Research. I worked on our COVID-19 state emergency declarations and mitigation policies data set, and today I'll be talking a little bit about that data set and related questions on correctional facilities, as well as our policy surveillance methods. Next slide. So policy surveillance methods includes an understanding of legal epidemiology, which is the deployment and scientific study of law as a factor in the cause, distribution, and prevention of disease and injury in a population. Policy surveillance can be defined as the systematic collection, analysis, and dissemination of laws and policies across jurisdictions or institutions, and also over time. So here on the right, you see a diagram of our process of collecting and coding laws with quality control measures in place throughout the entire process. Next slide. And so for our COVID-19 data set, this process looked a little bit different in that we rapidly conducted policy surveillance. And so we wanted to make this data available as quickly as possible. And in order to do that, it entailed a number of things, such as an iterative scoping process. We met regularly to discuss the scope of our questions and variables to make sure that they were in line and accounting for different aspects of policy response that were cropping up over time across states during the COVID-19 response. We also had to research across various sources. So we weren't just looking to Westlaw. We were looking at state government websites, agency web pages. We were also looking to things like press releases, because sometimes that was the only place information might have been available at a certain point in time. We saw an unprecedented amount of change in the law in this short period of time. And so in order to make sure the data was available as quickly as possible, we had to modify our redundant research and redundant coding processes. But to maintain quality control measures within this process, we also used secondary sources to provide kind of an external check on the way we were researching and coding and capturing these variables. Next slide, please. Like I mentioned, our COVID-19 data set is a longitudinal data set that looks at COVID-related emergency declarations and mitigation policies from January through July 1st of 2020. We looked at a number of different variables such as school and business closures, social distancing requirements, face mask requirements, and limitations on medical procedures. We also looked at variables related to state level requirements regarding correctional facilities. This included the type of facility, as well as type of requirements such as suspension of intakes, of transfers, or of other procedural requirements, as well as inmate release requirements. We also kept track of case law imposing correctional facility requirements related to these policies. Next slide. And here are just a couple of maps. On the left-hand side is a map of all of the states that had some kind of executive order with requirements related to operation of correctional facilities in place as of July 1st, 2020. And on the right-hand side is out of those states, those 7 that had implemented some form of a inmate release requirement. And so now I'll turn it over.
So I think one of the things that you get a glimpse of there is that the methods for this kind of legal mapping are more scientific, or as scientific as they are legal. There's transparency, documentation of each research step. There is a quality control that's also explicit and explicitly documented and in fact measured. There is the additional step of turning the words of the law into numeric data that can be used in a big quasi-experimental study. The importance of accurate measurement was highlighted in COVID-19, where there were some pretty high-level publications, for example, in Nature, of modeling studies attempting to assess the effects of control measures that used crummy binary variables like school closure, yes, no, and so missed the fact that, for example, in many jurisdictions, high schools were closed, but primary schools were open. That conflated gathering bans that covered, everything above 2 people with gathering bans that applied to everything above 100 people, and so on. So, although it's not fully clear on this model, because we just see the top level result on this one slide, these measures, often, I mean, there's thousands and thousands and thousands of variables across these six months, covering the granular details of the law. Part of legal epidemiology is to make I think, to foster an open source ethic of legal data. If people measure the law once, it shouldn't have to be done again by others. And there are a number of sources now where data sets, often 20-year data sets, can be found. The granddaddy of these sites is the Alcohol Policy Information System, which Alex Wagenaar founded. We maintain the Prescription Drug Abuse Policy System, which was originally funded by NIDA, which has, 15 or 20 different opioid-related policies. Again, longitudinal, sometimes up to 20 years, as in the case of medical marijuana. And then we have our sort of default data sharing platform, Law Atlas, where we again have dozens of data sets with data you can download on one click. Our final word goes to Jeff Swanson, who is a professor at Duke and an expert on mental illness and gun law. He was also part of our methods core at the Public Health Law Research Program. And he talks about something I think we're all very concerned with in legal epidemiology and beyond legal epidemiology, which is how we both study equity, that is to say, disparities and inequitable effects, and study with equity in how we do our work.
Well, yeah, I've written previously about this issue of racial inequities in the application of mental health law in particular. And so recently I've been trying to sort of translate some of that thinking and perspective to the problem of firearm restrictions. We have to kind of separate out the consideration of differences and disparities and discrimination from the immediate context where people make decisions that are discriminatory, and the upstream institutionalized ways in which these disparities are baked into our system way upstairs. So you could have a decision maker, who like deciding whether somebody should be on outpatient commitment or not, who could be completely colorblind, and you're still going to end up with what, in New York, the New York Lawyers for the Public Interest accused this whole policy of being racist because Black people were 7 times more likely to get on mandated outpatient commitment than white people were. But if you then go upstream and you say, well, let's look at who's actually diagnosed with serious mental illnesses and substance abuse disorders. Let's look at who's in the public behavioral health system for reasons of financing. Let's look at who gets involuntarily committed to the hospital. Let's look at who gets incarcerated, because that's another way people qualify for this. In our analysis, we took that apart. We just deconstructed it, and we looked at racial disparities using different denominators, right? The denominator of the whole population down to the denominator of people who are actually sort of eligible in the public system for this intervention. The disparity goes way down once you get to this very highly sorted population. Then the question you also have to ask is, when you using the IOM framework, you don't have just a difference, but you have a disparity because your difference is in need, or however you define it, is the intervention that is being delivered disproportionately to, say, young Black men, is that beneficial or is it harmful, right? So like to go to the firearms law example, in California, for example, and many other states, if you are involved with the juvenile justice system, you are prohibited from purchasing or possessing a firearm until you're 30 years old. You have to have this period through your whole adult, first decade of your adult life, crime-free, and then you can, even though your juvenile record might have been expunged. Well, from a public health point of view, we might think that makes sense because this is a high-risk population. We're going to save people's lives. But maybe if you are looking at it from the perspective of the person who says, well, you're taking my gun away and I need that to be protected, or looking at it from the justice reform perspective that says, well, we want to make sure people aren't, incarcerated, then you think, well, maybe we need to look at it from a different point of view. And then you look at some of these gun laws. For example, the North Carolina pistol permit law, which was passed in 1919, and it gives sheriffs this discretionary criterion to deny a pistol permit to anyone who lacks good moral character. And if you look at what was being written when that law was passed in the height of the Jim Crow era, it looks pretty transparently like it was a way to give sheriffs the discretion to deny a pistol permit to Black people who lacked good moral character. But now do we flash forward and say, well, this is fruit of the poison tree, so let's not have a pistol permit law at all because it originates in this. But many of our institutions today, just about all of them, have this origin story in a period where white supremacy was really underlying everything. So I think what we need to do is, among other things, bring this question of racial equity, racial justice, and front and center, and make it a really important outcome to study in just about every intervention we study, particularly those that have to.
So I'm going to quit this now, stop the share. I'm afraid that we started a little bit late, went a little bit long, but we have a couple of minutes for questions or comments. Please speak up. Let's see if I see any. I'm having a little bit of review here. Anybody want to say anything before we quit? I will say this, we at the Center for Public Health Law Research are here to serve people who want to do work in legal epidemiology. Particularly, we focus on mapping, but we help in lots of other ways. We have lots of resources available and lots of interest, lots of enthusiasm, and lots of interest in sort of linking people together across the world who are interested in this work. And it is kind of growing across the world. So be in touch, subscribe to our newsletter through our website, and otherwise just give us a call or send us an email. And I want to remind you that the presentations, all of which were pretty interesting and quite clever in their methods, are available at our website. This is, as what Bethany Saxon, our communications person, calls the non-sexy web address. Apparently, it soon will have something that's a little more memorable and striking than Node 1071. But you can use that and find the whole show at length. So we are now at 10:49. Just looking at, oh yeah, what is the website again? Oh, I'm sorry, it is phlr.org/node/1071. But I think if you go to our website and search for the National Science Foundation or Legal Epi Conference, you should find it pretty quickly. And by the way, our website is a repository of methods, tools. We have an entire section devoted to methods, methods documents. And Law Atlas also has a whole training page for people who are interested in learning how to do policy surveillance. That's lawatlas.org. So as I say, don't hesitate to give us a call. We are here to serve, and hope everyone is enjoying the LEAP conference, and we'll see you in another session. Thanks very much.